Good morning, everybody. Good morning. Thank you for coming to our 39th event of 2014. And like I mentioned earlier, this is our first time in South Carolina. Again, we would love to be able to do more programs here. We were in Charlotte earlier this year. It feels like a year ago already after doing 39 programs, but it's not. It's still all part of this year. My name, for those that don't know, my name is Stuart Schlossman. I'm president and founder of MS Views and News. And for those that don't know, I too have multiple sclerosis. And it was when I was diagnosed and I could not find information that I wanted to make sure that everybody's going to be able to find with what was not available years ago. So we started with a newsletter that started with just reaching 5 people in a small area and now reaches people in over 90 countries. And our database exceeds 30,000 at this point in time. So again, we want to thank you as part of being our database these days, and we hope that you learn from us in the future. For today's program, I want to thank Genzyme and Mallinckrodt for their dollars to help us do this program. I'd like to thank them. I hope you all do too. A little round of applause. Thank you. Without the dollars from the pharmaceutical industry, MS Views and News could not provide the types of programs we do. And we feel the need to provide these programs for, like I said, it's just that there are a lot of people that don't know what's available for them, and so we want to make sure these programs get to them. In addition to Genzyme and Mallinckrodt, we also want to thank our other sponsors that are out in the hallway today, as well as our support group leaders that are out here that help to provide the information of what we're doing, as well as our own staff and our volunteers that do for us all the time. Of course, we have for our agenda today is Dr. Mrelashvili. Did I say it right? Oh my God, I don't know if I did or I didn't, but we want to thank him for coming here today. And Jessica Thomas, she came in from all the way from High Point, North Carolina to talk with y'all, okay? So before they begin, though, I want to ask 3 different support group leaders to come on up, and they're going to speak with you for about 90 seconds about their groups. Let's start with Bob No. And then, if you don't mind, Tim, if you could come on up, and Sandy, if you come on up, you're going to be speaking right after them. You got to walk faster, yeah. Run if you can.
Hi, I'm Bob Noe. I'm one of the co-leaders of the Columbia Afternoon Support Group. We have a group that does an amazing amount of stuff besides anything you would think of that a support group would do. And I want to invite everybody to come to our group if they would like to. There are other good groups in Columbia. But I first would like to introduce you to Sandy, who's my co-leader, who has all the details of what our group does. I just run the group. She has the details. This is Sandy.
Thank you. Hi, I'm Sandy, and I'm co-leader with Bob of the support group. And our group is just so much fun. It's for sharing information and experiences. For example, somebody will mention, it's so hot outside and I can't, I like to do this and I can't. And I say, hey, have you tried a cooling vest? You can borrow mine. Other things, somebody came to our group and they had Nordic walking sticks and said, I got these, they help me walk, and so we all tried them out and I said, yeah, those really do help you walk. AFOs, does that help you with the toe drop? Yes, it does. Try it, and so we share information. And just like somebody might mention that they have spasticity and that the baclofen, oral baclofen is no longer controlling it. We'll say, have you tried a baclofen pump? And before, the only place you could get your baclofen pump refilled was maybe out of town. But now there's a doctor here in town who puts them in and will refill it. So instead of going to Augusta every 3 months to get a baclofen pump refilled, we can get it done here. And also, this doctor is coming to our meeting on January 26th, and he's going to speak about the baclofen pump, so you can have a resource right here in town. We had a program called Everyday Matters, and the people who attended this program, they felt it was the most wonderful experience. We formed so many good friendships. It was a life-changing experience. We're going to have USC is coming, and their group is called ABLE, and it's for better health. They're going to teach, we're going to have 8 classes talking about diet, exercise, balance, attitude, and these are taking place in January and February. We have, that's it. Huh?
Thank you, Sandy.
Okay, you're welcome.
Come on, Tim, you're up next. Sorry about that. Easy. Come on. Oh, sorry. Next we have Tim Goodwin, right?
Goodwin.
There you go.
Yes, good morning. It's lovely to be here today. I thank God for the opportunity to do this. I thank MS News and Views for the opportunity. We look forward to a relationship with them. Look forward to a relationship with those of you, especially if you don't have a support group. I'm a support group leader. Thank you very much. Y'all have a good day. Enjoy.
So I missed one name. We have Ranva Gooden from somewhere here in South Carolina. She'll introduce herself in about 3 seconds, she told me. Come on up.
Good afternoon, everyone. Hi, my name is Ranva Gooden, and I am the co-leader of the newest group that meets here in Columbia. It's called Let's Talk About MS. We've been meeting for about 4 years now. And once again, we are the newest group that meets in Northeast Columbia. We meet at Providence Hospital Northeast. We meet every 4th Monday at 6:30. And I have a few flyers with me, and I can share them with anyone who's interested. And once again, the group is Let's Talk About MS, and we meet every 4th Monday at Providence Hospital Northeast. Thank you so much, y'all. Have a good afternoon.
So I would greatly recommend that whoever's not attending a support group, that you do get in touch with one of these people, because it is a great feeling to know that you're not the only one going through something going on with your life, especially with multiple sclerosis. So first up, we're going to have, again, Dr. Mrelashvili, Dr. M, all right? It's a lot easier for me. And Dr. M is going to speak for about 50 minutes, plus do a Q&A. All right, so again, we'll be talking for about 50 minutes plus Q&A. Please hold all your questions until we actually start the Q&A. Write them down, make notes, whatever you want. And then after Dr. M, we're going to have Jessica Thomas come on up, and she'll speak with you for about 40, 45 minutes, and then we'll do Q&A with her as well. So let's thank the doctor. Come on in, please. Thank you.
Thank you very much.
Thank you.
All right. Well, I want to thank Stuart, first of all, for inviting me. I'm slightly shorter than you, so let's adjust it. No, I'm good.
You can take the mic out there.
I can probably
Take the
stand
mic
here.
out, you can walk around.
Yeah, you know what? You're
You have
right.
that to look at
That's
over there.
cheat sheet.
There you go.
Cheat screen. All right. Well, if at some point my arm drops and you can't hear me in the back, just make some sign. First of all, welcome everybody. I'm glad to see, actually a lot of familiar faces. I give quite a few talks here, branded, unbranded, different topics, and I'm always glad when the same person shows up. It speaks of loyalty. And sometimes I blame the food if it's too good. But anyway, let's get started, because Stuart is one of the most punctual people that I've met. He's very discreet about it, and actually it's, it's a good feature. Let's get started. Now, he gave me a very ambitious goal of talking about all this in 50 minutes. And I'm like, okay, well, I'll try my best. And luckily, we have quite a bit of Q&A session at the end. So if you feel like there's a flood of information coming through the mic, especially with this harsh Russian accent, try to write down if there's something you couldn't quite catch, and we can clarify it later on. So let's talk about, these are the goals. So invisible part of MS, it's a relatively, well, it has existed all along, but a relatively new thing that it's talked about, and we'll talk it in depth. Definition of what relapse is and treating the flares, I think it's always a important and a sort of helpful topic for the patients. Then I divided the treatment into two parts. I can't, kick my habit of actually not looking at the screen when I have one here. Dividing the treatment in two categories, one sort of an older traditional, what they call platform therapies, and the second one being newer agents that includes pills, is the way I formatted this talk. So, what are the invisible parts of MS? The easiest way to define is the ones that you feel, but others can't see, okay? But to the most extent. And you have good examples of it here. Mental fogginess, concentration, memory problems, kind of divided into mental, cognitive part, and certain physical ones that a lot of people don't necessarily see, such as pain or optic neuritis. Optic neuritis when you cannot see, but others can't see that you cannot see either, kind of thing. And the pain is kind of a big category that I wanted to include here because it's a very sort of tenuous topic and hard to address at times. Okay, so why are they challenging? As I said, it's really hard for the person to notice it, for other people to notice. That way, it's harder for them to empathize, could be considerate about those symptoms. It's usually harder to talk for the patient as well, with the doctor or even with the family member, spouse, etc. Very hard to measure, it's hard to measure the pain, it's hard to measure the memory difficulties with a number or something discrete. And this is kind of very important, less addressed by job or government, especially as far as disability. I could give you plenty of examples when I have a patient who looks normal, but they can't function at their previous job. One example that comes to my mind is a lady who used to work at lawyer's office as a paralegal, and you can imagine how much of mental work she needs, and she got all these on that left column that I had in the last slide, all these, and then go figure, like there's no number you can put to it. So she was really struggling. And of course, they're pretty hard to treat, most of them. Cognitive difficulties. Now, I'm going to be stressing the ones that I think, all these lists here in the equal size fonts just to create the symmetry on the slide, but some of them are really important, and I'll tell you one of them that's really important is the medications. But not the ones that you can treat it with, the cognitive difficulties, but the ones that actually you're treating something else, so side effects. Sandy, I think, mentioned baclofen here, and it is as great as it is for spasticity and muscle spasms, etc. It can be terrible for your mental fog. I mean, if you get a side effect, I'm not saying it's a bad drug. For certain people, it may be, but so look over all the medicines that you're taking, and some of them may be causing like dramatic side effects. Even the MS medicines that you need to take on, some injectable drugs, can cause depression or other mood swings. So be mindful of there. Maybe actually it's not the MS, but something else that you're taking causing all these cognitive side effects. It's okay to get organized. Get reminders, alarms, especially taking your medications, to create the list. This is something that's very overlooked. Like nowadays we have all these smartphones. I have like 3 different apps on my smartphone to remind me things, including today's talk. Okay, so people who don't have MS, they use it as well, so why not use it? If it's going to help you, if it's going to make your life easier, it actually does help. Adjust your duties. It's okay to lay back a little bit, to let others do things that you used to do in certain cases, especially if it's family. It's okay to get help. Because think about it that way. Forget about MS. Like, I can do things that I used to be able to do 10 years ago, okay? So MS just kind of amplifies the effect of what everybody else is going through by just aging. To the most extent, of course, there is some MS-specific hardship and difficulties, but you really, especially it's for type A people who are always active, always used to be in charge and control, it's very hard for them to let go, literally speaking. But you really got to do that at some point. There's plenty of mental exercises that actually work. And it brings me to the last point here, that medications for the cognitive difficulties, memory problems, usually do not work. They don't exist. We have like medicines for Alzheimer's disease, but nobody has really proven that they increase the memory or cognitive clearance in MS. But a lot of lifestyle modification, anywhere from, as I said, like a healthy lifestyle to mental exercises. There's a bunch of them. I think the National MS Society has some on the website, the recommendations. One that comes to my mind always is luminosity. Now, I'm not advertising it by any means. It's just one of the things that's out there that I've heard helps some people. But I would choose the free one. I wouldn't pay anything for it first to try it out. So those are some of the others. Now, mental problems. This specifically refers to mood swings, anxiety, depression. It actually, MS patients have two reasons to have them that most people don't think about. One is the actual chronic illness. Somebody being sick makes them prone to depression. Like 50% of Parkinson's patients are depressed because they have Parkinson's, okay, or asthma patients, stroke patients, etc. Now, so that's one. MS is a chronic illness. The second one is that patients can actually develop what we call organic brain lesions. Develop a lesion in the area that controls your mood, or vice versa. It usually doesn't make you too happy. It usually makes you more depressed for whatever reason, the way the brain is organized. You can't hit the spot to be happy all the time. So that's another point I was trying to make. Now, one of the biggest challenges, especially in mental mood disorders, is to recognize the actual problem. A lot of people have a hard time bringing it up to the provider. Usually it's a spouse or a family member, significant other, however you call it, a friend, who is with the patient who would say, hey, I think he or she is going through some really rough times, and even though it may not be notable at first glance. So immediately bringing it up is really important. Now, I was talking about important things, right? Eliminate the cause is huge. We people are built the way by nature, God, to get used to things. We get used to things very quickly, and we think it's normal, okay? Anything starting from medication that you may be taking for MS, certain medications can cause depression, especially interferons, to any other medicine that can cause, that you may be taking for additional symptom, to a stressful work. I have plenty of patients who tell me that, hey, my boss stresses me out. Well, of course, it's easier said than done. But think about if you can make that change. It can actually make a world of difference in a daily life. So that's there. I especially like the word people here, because we are surrounded by some people, unfortunately, whether we want or not, who may make our life more stressful. Try to put them in more distance, if you can afford it, of course. We could take this conversation anywhere, but I'm going to stop it there. And I guess medication to treat the mental condition is usually my last resort, starting from some sort of a generic, initial first-line pills for depression would be the simplest example, to referring them to professional counselor, depending on the severity and the duration. So all this is treatable, so please seek help. This is the first step to actually get things done. Now, physical, I try to kind of make the more key points in this. Of course, this is treating optic neuritis. It's a huge topic. I couldn't give you all at once, but for you to know what it is, it's basically eye nerve inflammation. It's one of the most common presenting signs for MS. It usually is characterized by painful eye movements. When people are asked to look side to side, up and down, they feel pain in the eye. And usually vision gets blurry. And usually it's one eye only. There are cases, however, when it's both eyes. Okay, it can happen, but not typical. One of the things about this eye nerve inflammation is that you need to immediately get hold of your healthcare provider. The sooner you treat it, the better or faster the improvement is usually. So make sure if you're unable to reach your doctor for whatever multiple reasons that happen in real life, going to the ER for this purpose is absolutely reasonable. Okay, this is something you need to treat it sooner. Bowel bladder problem, extremely common, 90+%, especially for bladder. Oftentimes not talked about. Again, depends on person's level of comfort with a provider or even with a family member. But very, very common, and it's it's actually very treatable, starting from an easy lifestyle modification such as rationing the fluid intake. Now, I never say don't drink fluids. No, just drink them at the right time. When you're close to the bathroom or you're not in the middle of a 2-hour trip and the train has restrooms. You know what I'm saying. And avoiding the substances that just kind of flush you through, like caffeine or alcohol, they actually dehydrate you more. The amount that you drink, you put out twice more, or figuratively speaking, twice more, but you actually urinate more. They dehydrate you, okay? So be mindful of that. And, simple things like if it's a small leakage, like using pads, it's okay. If it's going to make, avoid you from running to the restroom out of, some important meeting, it's perfectly reasonable. Learn to adapt, learn that a lot of things are okay, really. It's hard to say enjoy the sick role, but it's if you know that you have an illness and that's there are certain things that are normal with this illness, including some of these measures that when you were not ill, you kind of looked like, ow, I can't believe I could do. I don't know if I could do that. Okay, so I think it really boils down to flexibility of the mind that will be very helpful to develop earlier on. Pain in MS. I think it's a painful topic for both patient and MD. Unfortunately, in society today in the U.S., there is a skepticism, in the absence of a better word, to pain. People who are having pain, because a lot of people who are seeker for narcotic drugs, that's a reality. So doctors sometimes look with a caution, and I don't blame them. I think they should. Who has what pain, how to treat, etc. Well, in MS population, I think it's one of the most legitimate, one of the most genuine population that really hurt and are really pain seekers. There are certain classes of patients that is higher incidence, lower incidence, pure statistics, not trying to classify somebody. But MS population, my personal experience is that they really hurt. And it's based on the disease. And it's relatively novel, new thing that in the past used to be underestimated. It could have any simple cause such as muscle spasm, contractures, but it could be just no particular cause that you can point, other than somebody has a lesion in the spinal cord that conducts the pain pathways, and it just keeps irritating them, like a little stone in your foot or a shoe. Okay, that's this is, again, more like a review. I would like to get into details of each of them, but for the interest of time, we can't. But I can tell you that prevention can take you a long way, especially for contractures, muscle spasms, things like that. Exercising, stretching your tendons, with proper caution, of course. Make sure you don't fall and things like that. No physical injury. Now, pain medication is something that I really, really wanted to address. Yes, they exist for a reason. They should be used in proper cases, but try to get to them the later the better, because they're literally one step forward, 2 steps backwards, because they're really made for a short term, because if you take them long term, it makes the body's own pain defense very lazy. It's very similar to when you take antibiotics chronically, it actually gives you more infections. Very similar. So I've seen many people sort of getting in that spiral of down-going spiral with the pain medications. That you have to increase the dose and so forth. So, but again, there is definitely they exist for a reason, and they should be used in MS patients, I think, in proper cases. Okay, let's switch gears a little bit. Go to relapse. We're doing pretty good on time. I'd like to talk about first what is not a relapse, because I think it's equally important. If you could know everything that's not a relapse, everything else, I guess, could be relapse, or vice versa. If it's only 2 options here, either it is a relapse or not. My biggest announcement about this topic is that when in doubt, ask your MS nurse or MS doctor, whoever you have an access. They're usually pretty good engaging what is relapse, what is not. And there is a gray zone in the middle when doctors like, yeah, it could be, let's do it just in case, give you these steroids, etc. It's not like a blood test, like you either have high cholesterol or not. You can put a number to it. It's not. It's a lot of it is clinical, and you don't always get MRI for it either. So, but let's talk about what's not relapse. So, when somebody's brain has MS, is a sort of a background process running in the background in the brain. Any external factor can temporarily make things worse or better. Like when I say external, things like overheating, I think was mentioned earlier. Medication side effects, plenty of them. Most of the medicines that we use for symptoms actually make MS patients feel worse. Fever, infection, exhaustion, just simply end of the day, people feel more fatigued. And they ask, well, if it's, the general rule of thumb is that if it lasts less than 24 hours, it's usually not a relapse. Now, there's a little footnote to that. There are certain things that I would not wait for 24 hours to see if it lasts longer. For example, you woke up and you can't see out of one eye. Well, you don't clock yourself. Is it going to get better? We're talking about more subtle things usually, whether they would get better or not. Same thing about being paralyzed in one leg or both legs when you wake up, and technically has lasted since you woke up, but you really shouldn't wait for those obvious things. Can everybody hear me in the back, just in case? Okay, very good. Just make sure. Okay, well, let's talk about what are the symptoms of relapse. I think it's easier to say, instead of what are, what could be. Because literally anything and everything that you can think of that the human brain and spinal cord controls, if it's gone wrong, it will be a relapse. And we can talk about parts of the brain that control coordination, dizziness, balance difficulties. We talked about the optic nerve or eye nerve, blurry vision, vision loss. There is an interesting phenomena that a lot of patients, a majority of the patients, and I would say quite a few doctors sometimes either don't know or don't think of. I'm talking about non-MS specialists and even non-neurologists, okay? It's a spinal cord. It actually is a source for many more symptoms than you think about in general. Everybody does the brain MRI, everybody counts lesions in the brain, but ultimately what makes people being unable to walk, 90+% of cases, it's a spinal cord, okay? Now, why don't we talk about spinal cord then? Well, because it's kind of easier to look at the brain because of its size. It's bigger. We can have better quality images on the brain. And usually what's going on in the brain is somewhat parallel to the spinal cord. Now, I'm not saying you can count the brain lesions and interpret as how many spinal lesions you have. No. But it's almost like when you check in the car oil. Okay, for some reason I like cars, so I bring a lot of analogies. Well, you don't actually take off the oil pan from the bottom of the car when there is 5 quarts of oil and, look at it. You have a dipstick that you put down, you pick it out, and look at it, and it gives you an idea what the oil looks like. Well, your brain is kind of like a dipstick for what's going on in the on the spinal cord, even though technically spinal cord more looks like a dipstick, and flipped over. But yeah, this is a lot of times symptoms that's below the neck very frequently are coming from the spinal cord lesions. I just want to let you know. But they're treated the same. They also need the same DMTs, disease-modifying treatments, same steroids, etc. It's just pointing where the lesion is. It could help you conceptually. Any arm, hand weakness, bowel, bladder problems, almost always spinal cord. Sexual problems and sensory disturbances, equally same way. Okay, so after we know whether we have an attack or MS flare up or not, how do we treat it? Can I have a little glass of water or something? If somebody, hey Stuart, could you ask him for a glass of water or something? Yeah, I'm not choking, but I think I'm going to need it at some point. So treating MS attacks. Now again, thanks so much. That was quick. Got it. I'm going to figure out how to. Pardon me? Oh, yeah, that's right. Actually, you could even stand here, but let's see. This is a fancy one. This one, right? Oh, here? Oh, yeah, okay. You can actually stand here, so it's fine. All right. So, after we have determined that it's an MS flare-up, and I want to say that the flare-up, exacerbation, and attack mean exactly the same thing. A lot of patients hear different terminology. Across the board, it's the same. Don't let things confuse you. So how are they treated? Well, a lot of times we also ask ourselves, how severe it is. If it's just a little numbness in the finger, not all the doctors would slam the patients with big dose steroids, but most often it is treated. If you call it a flare-up, you treat it with steroids. That's the general rule of thumbs. A plasma exchange, somewhat experimental, well, not experimental, more of a, not officially indicated, but when we exhaust all the options, then we kind of go to that. Rarely, very rarely, I would say. There's another option, Ecthar, that I'll talk in the next slide, I think. So what is, a lot of times, well, quite a few times, I've had patients asking me, getting a little confused, so why, if steroids help, why don't I take all the time? Well, you cross a line where they stop helping you and start hurting you, okay? And it's usually after a few days or a couple weeks, that's when that line happens. Steroids, by all means, are indicated for a short term. There was a number of clinical studies that did steroids all along. It did not help and did more harm. Okay, so unless there is a very special circumstance, and I can't think of any right now off the top of my head, I think being on steroids chronically, daily, for months and years is not an option for MS. That's a difference between what they call DMTs, and this is one of the another fancy term that I want to clarify for you. So anytime you hear DMT, you know what it is. It's basically any of your mainstay MS drugs that you take either daily or every other day, weekly, etc. It's like they come in all flavors, every 2 weeks and every month, and now they have every year. Lemtrada just came out. So the one that you take it for your maintenance MS treatment to decrease the flare-ups, that's your DMT, or disease-modifying treatment. Now your relapse treatment is the one that's given only during the relapse. It's a short term. It's just to speed up the recovery from whether it's optic neuritis or weakness in the legs, etc. It's usually done more for treatment of these flare-ups rather than prevention versus prevention in the case of DMTs. So here's the couple options that we have treating acute attacks. Majority of the patients are given corticosteroids. It's a general group term for medicines such as what you've heard, prednisone, solimedrol, methylprednisone. Anything that has that name for it falls under the umbrella of corticosteroids, a group of drugs. And usually done 3 to 5 days. Based on studies that were done years and years ago, that's what worked, so everybody kind of sticks to the same thing. 1 gram once a day. If they cannot have an IV, there's been an alternative regimen proposed to like 1,250 milligrams, but I usually don't like it. I like it IV as well. It's harder on the stomach, I think, by taking it PO. But again, there's not a whole lot of clinical evidence behind it. Now, some people do this, what they call bimouth prednisone tapering. For example, starting with 60 milligram and take off 5 milligrams every day until finished. And that also has a very limited evidence that it does something, but patients have reported that, oh, it helps me to get better. Now, whether they would have gotten better without this oral prednisone as well, God knows, probably, I would think so. But, you know, if they perceive as it's helpful and it doesn't have a whole lot of harm to it in the short term, I think that's what prompts a lot of doctors to do it. Another drug called Ecthar, some of you may have heard about it. It's another FDA-approved treatment. It's used less often. It's almost like a second line if somebody cannot get steroids as a first line, whether they don't have IV access, whether they don't have... I had quite a few patients for who insurance doesn't pay for going to the infusion center. And that's what it's good, because it could be self-administered either under the skin or in the muscle. Let's see. Side effects are pretty similar between the two drugs that are used for the flare-up. Probably most of you have taken steroids and know how it feels, so I wouldn't spend a whole lot of time in explaining what they are, but they range anywhere from just feeling, you know, kind of jacked up, revved up, as they use the slangs, to actual bodily side effects, such as very much increased glucose tolerance or diabetes worsening, risk of bleeding or ulcers in the stomach. Those are some of the major ones. Of course, weight gain increases with the longer you take, the more it is. Some people report that they gained 5 pounds in 2 days. A lot of it is a fluid retention that actually gets better, because prednisones, the steroids help you to retain fluid, so you kind of keep everything that you drink. So that's not a pure fat, or I guess that's the right term, weight gain. All right, well, we're finally getting to the major part of the talk. I think that a lot of people are wondering. Medications to treat MS, and of course, Stuart wanted to be all-inclusive here as well, and he asked me to talk about all of them. That I think it's pretty hard. I could spend 1 hour talking about one medicine, and now we need to have like 20 minutes or so for a talk about 10 of them. I actually purposefully skipped midazolam. That's rarely used, somewhat very toxic drug that I personally have never prescribed in 6 years of actually being an MS neurologist. Never needed to, and it can cause some serious side effects. And it was mostly used before my time as well. Now, this would be the last resort to me. I think it's not that it shouldn't be used. It's still approved. It's still out there. It still exists, but it's a little rough on the body. So these are your ABCR drugs that they call. Glatiramer or Copaxone is the one that's C, and your relatively newer agents. We'll talk about. So again, for the interest of time, I could not talk about every single interferon separately. I group them together as beta interferons, your Avonex, Rebif, and betaseron. They have, in general, they are deemed to be about the same efficacy, except there was one study that said that maybe higher dose interferon beta A, that's Rebif, it could be a little more efficient or effective than Avonex, because, well, you're giving more dose more frequently, so it's kind of logical too. Now, there was also a study that in switching around the medicines for no reason is no good either. So when I talk about efficacy, please do not take it as somebody, I want to take the strongest drug. No, it's if you're taking, let's say, theoretically, a weakest medicine and it's working for you, that means it's the strongest one for you, okay? The numbers on the paper are general numbers, not individual. So it's very important to know, because that the drug that has less efficacy for some reason may be the safest as well for you, and it could not. So try to not to make any further conclusions than what I specifically state. I want to be very careful about it, because people see some numbers or graphs, and one of the bars is taller than the other, and they all want to switch to that drug. It doesn't work that way, of course. I mean, if that was the case, we all would switch the patients to that, but it's not always the right thing. So just to go back, they all come as injections, usually once every other day, 3 times a week, or once a week. And I think Avonex just came out with every 2-week formulation called Plegridy. It's essentially the same drug. They just kind of extended the twice less shots. Why not? They all share very similar side effects. Injection hurts, they have different. The needle size though has been getting smaller and smaller, so at least that part is good. It's more tolerable. Flu-like symptoms, fever, headaches, muscle pains can be the side effects. Depression actually is one of the potential side effects of any of these. So if you have a depression or are on these medications, definitely something to bring up with your doctor, saying, hey, could be the combined effect of the drugs as well causing or helping depression, helping in a bad way. Depression. Copaxone is a sort of a type of its own, a different kind of molecule. It consists of a bunch of amino acids, those 4 amino acids. That's what they GLAT, glatiromer. This is where it comes from, fancy chemical name. Bunch of repetitions, like multiple copies of it, so to speak. And it's 20 milligrams once a day. Actually, I can't believe I forgot to add on it. They came out with a 40 milligrams every other day now, or 3 times a week now. So it has 2 doses. You can do it both. But it's the same drug, same effect, same efficacy, same side effects mostly, except, injections are twice less frequent, at least, a little more. Now, side effects on this one are injection site reaction. Sometimes there's a redness. You see this little, however you describe this, skin redness. Pretty common chest tightness that's usually not harmful or dangerous. People are scared if they're having heart attack. I'm not aware of any heart attack that Copaxone caused. However, a person, if they have other risk factors, high cholesterol, eating bad food, etc., they may have a real heart attack and be on Copaxone. So if you have something like that, of course, it's better to seek an attention. But it's not necessarily linked that Copaxone causes it. Certainly, there's an advantage that the reduction in MS relapse is about 30%. And this 30% or low 30s has been the magic number for most of the platform therapies, those Avonex, Rebif, and Betaseron. They all about reduce the relapse rate by about 30-something%. Now, it's really hard to compare them, saying that, is this 32 more than, 30 for Copaxone? Really hard to make the statement because studies were done at different years, different population, mostly different definitions of what the relapse is. So it's not apples to apples. I wanted to let you know that. And there is some evidence that Copaxone takes a little more time to kind of kick in and has a little less effect on MRI reduction of the lesions compared to, well, you can't compare. Again, I can't help the word finding, but in contrast to the other studies that were done on interferons. But it's deemed to be a little more, well, how to say that? It needs no monitoring. It's one of the few drugs, I think, or the only drug in MS, that if you are on it, you don't have to watch your liver, blood count. So it's generally deemed pretty safe to tell you about that. Oral therapies was a big hit. When they initially came on the market, I think I was convinced myself that a lot of patients would be switched over to orals, and it did happen, probably less than what I thought. But it definitely, they made a difference. Well, when you think about it, the main advantage obviously is the shot versus pill, right? That the mode of administration is probably the thing that jumps out the most, and it's definitely an advantage. You would think is a better adherence, like they take it more meticulously. But there was some mixed studies, like there's different studies showed that it's not necessarily always that because you're taking a pill, you're forgetting it less. Not always the case. But you would think it would be like drastic difference. And of course, no injection site reactions. I kind of listed some disadvantages here. It has a longer common, but it's not because it's, it has more disadvantages. I just like to be cautious about everything new. Safety profile, uncertain is probably a little too strong word. I would say its track record is shorter than with injectables, and it's the nature of the beast. I mean, if something is new, it automatically comes with the fact that you don't know that it's safe in 20 years versus about certain injectables. You know that in 20 years, nothing unusual happened, and it's just true across the board for any new drug, not just oral drugs. Dearth of a head-to-head clinical trials. There's been a couple that they compared to, for example, they compared Gilenya to Avonex, and there's of course a bunch of critics came up and said, "Oh, it was not a good." I quit comparing them. I started more saying, "Okay, is this the right drug for you to try? Let's try it." Then my next question is, does it work? Yes or no? If it doesn't work, next. That's whether putting them like head to head and trying to come up with which one is the best. We were not there yet to predict which drug would work better for a particular patient. I've had plenty of patients who were better controlled on the drugs that are generally perceived to be not as strong, and actually doing worse on the drugs that are perceived strong. So it's a general rule of thumb. I keep repeating it, coming back to it, but it's really important for you to understand. Try not to direct your doctor's care, because I've had some patients who really want to, take a particular drug, and the rationale behind it is unfortunately a flaw, like not a right logic, usually. So a lot of times they require monitoring because, again, being cautious of they can cause some side effects. These are some of the three medications approved by FDA: Gilenya, Aubagio, and Tecfidera. Start with Gilenya. Just put them in the order they were approved, no particular other order. Interesting mechanism of action. What this round thing is your lymph node. Okay, don't bother reading all the little abbreviations here, but what the drug does really, it traps your immune cells into the lymph nodes all over the body, so there's less available to go and attack your brain. That's what happened in MS. Okay, your immune cells are gone bad, and they go to the brain and the spinal cord and keep causing inflammation. Well, the idea is if you have less immune cells circulating, they'll be less available to cause trouble. Okay, that's what they do. Basically, lock up those immune cells inside the lymph nodes. This process is luckily reversible. You can stop the drug, in a couple months, all blood cells come out back in the bloodstream. Okay, so there's a number about 70% gets sequestered in the lymph nodes. And don't worry about this SP1P. It's a little more for, very people who have more interest in depth. That's usually makes less of a difference for the patient himself or herself. I put in some very basic data from the clinical trials that FDA believed it was good enough that they put the drug on the market. For fingolimod, there was a couple of them. One of them, Freedoms, they compared the drug with a placebo or a sugar pill. They had over 1,000 patients. And while, just to kind of simplify things, placebo relapsed about 0.4 per year. That means that somebody relapsed again, to put it in other numbers, every 2.5 years, somebody had a relapse of this patient population. When they put the patients on Gilenya, the 0.5 milligrams, this is the one that was approved, they had relapse in 1 in 5 years or even less. Theoretically speaking, the study was smaller. It was a 2-year study, I think, yes. And but they extrapolated, like they blew up the scale to see theoretically how long would the person last without the relapse, and this was approximate number, 0.18. So 0.18 divided by, or 0.18 over 0.4 is 54%. That's how you get it. So it's 54% reduction in relapse. So this is just to demonstrate what these numbers mean to you, and I'll be using the similar numbers on the other drugs as well. There was another study that compared it to Evanex. It was a 1-year study, and the same numbers. The relapse rate with Evanex was 0.33, so exactly 1 out of 3, every 3-year relapse, theoretically speaking. And it was similar to, actually even less with Gilenya was 0.16. So again, 1 in 5 years or less, maybe almost 1 in 6 years. So it was twice less relapse rate in this 1-year study that they did, you could tell. Side effect, of course, whatever is good always has some downside to balance it. Some common ones are headache, diarrhea, cough. Liver enzymes can be elevated, just like majority of the MS drugs can cause this. Dropping in the cell count is what leukopenia is. That we know that's how it works. There was one death that's notable to say in May of 2012 that after the first date somebody went home and died. Now, you're going to be hearing a lot of this about other drugs as well, and just to put it in the perspective, there's about 100,000 people on the drug presently, I think, and one of them had a clear, well, not clear, but very likely link to the drug that within 24 hours died. So it's 1 out of 100,000. I was looking up actually today about risks of dying from different causes, and risks from dying for a car crash is 1 in 100. That means any of us dying from a car crash has 1,000 times bigger risk than dying from Gilenya, like in the first day, whatever the death. Theoretically, I'm just putting in numbers, and and this applies to other drugs as well. When you see reports from one person in Australia died from it, it just tells us that how many of us don't get in the car because we are scared to die. The same way, if the drug has a rare side effect, not being on it there's something you should definitely consider. I'm not saying, it's nothing. No, but put it in the perspective of real numbers. Okay, how important it is. Now, that's not the only thing, though. European Medicine Agency, similar like European FDA, actually linked 15 other cases that could be possibly related to the death. Now, FDA is a little less strict because the way the medicine is practiced here is different from Europe. They're more aggressive there, etc., etc. But this is the information. I'm just a presenter. And I want to make sure that you interpret it in the right way. The rest of it, you are the judges. So those were the things, mostly from the cardiac cause. Some of them, somebody drawn, I think, was not all of it was to me related, but at least that's the report. Now, reasons to be cautious about getting on Gilenya: if somebody has heart problems of multiple sorts, or, for example, stroke or mini stroke, etc. So usually doctors are supposed to do all the thorough screening about this drug to make sure the patient fits the right criteria for it, doesn't have any increased risk of developing any additional heart problems. So the way they do it is that they do EKG prior and 6 hours after giving the first dose, and you actually spend the 6 hours in the doctor's office and are monitored after you take the first pill. The reason 6 hours because its effects on the heart peak like right before 6 hours, and they kind of drop. So if you're okay for 6 hours, usually is the case. Supposedly there'll be less problems in the future. Of course, if somebody has any dizziness or syncope or any other complications, they watch them overnight in the facility of some sort, but again, it's relatively rare. Other side effects, it can cause, I think it's 1 out of 250 cases, can cause swelling in the back of the eye called macular edema. Again, that's one of the reasons that before you get started on this drug, you have to see ophthalmologist, make sure your eye is okay, etc. There's a couple people who died in the trials from higher dose drug that was never approved. It's from viral infections. Again, conceivably because of it drops your immune cell count, so your defense wasn't as good. But again, that dose has not come to market. They didn't approve it. They were taking less dose that supposedly has less side effects. So you got a vaccination. There are non-immune patients. You have to do 2 doses at least 1 month apart, and treatment should start 1 month following the second vaccine to make sure immunity has time to build up, because while you're on Gilenya, vaccination may not work as well. And there was a case that somebody had a skin cancer of melanoma back there. It's kind of a rare thing, but worth mentioning. Okay, well, these are the monitoring that you do. Eye exam, blood test, EKG, obviously, for the heart. Pregnancy test is true for every MS drug, not just Gilenya. And skin exam, make sure nobody has any melanoma. And this is what you do before starting, and this is what you do at the first visit. You go to doctor's office, get an EKG before starting, make sure your heart is beating right, take the first dose, and watch the heart rate, blood pressure, and the EKG afterwards. Monitoring, usually the main one is eye exam that's recommended every, first 3-4 months. And yearly, after, if somebody has diabetes, that would increase the risk of eye complications. The blood work for the liver function test and the white cell count, it's kind of questionable. I think a lot of people don't do it, but if you want to be cautious, do it. And again, dermatologist exam because of a skin cancer is also somewhat flexible, I would say. It's not mandatory. Aubagio is another medicine that came also known as teriflunomide. It comes in 2 different packages, once-a-day pill. So its mechanism of action, it's related to one of the drugs that was used in the past, leflunomide, used in rheumatoid arthritis. It inhibits synthesis or building of one of the building blocks of DNA called pyrimidine. By this enzyme, the hydroorotate dehydrogenase. Probably this is the last thing you want to build up your memory cells. It's not really relevant, but it does reduce the certain proteins in the brain that's thought to or immune system that's thought to play a role in the MS attacks, and sort of blocks its T cells. It's one of the types of immune cells. Blocks them from interacting with each other, so the word doesn't spread, so to speak. Okay, let's attack brain. Okay, it does have a long half-life, 10 to 18 days. So if you have to stop it, make sure, and you need to wash out from the body, you got to wait for several months at least. And this is the chemical structure of the pyrimidines that I talked about. Okay, a couple of trials that they did. Also, it's very popular to do trials at least on 1,000 patients. And they did it for a year or 2 years, and this was a reduction. The placebo patient relapsed pretty often. It was sort of heavier population than some of the other trials that we did. It was 0.54. So that means average patient relapsed every other year on placebo. On Aubagio, it was pretty comparable in both doses. It was 0.37, so approximately once every 3 years, a little bit more. Once every 3 years would be 0.33, so a little bit more than that. And it did decrease the disability progression as well. There was another study, Tower study. They did it's a phase 3 study, means a large scale, kind of high quality study. Did 14 milligrams and 7 milligrams, and 14 milligrams was the one that actually reduced disability progression at 12 weeks. That was remarkable. Okay, there was one last study, Tenir. Again, they compared it with interferon beta 1a, that's Avonex, and the endpoints where they saw the treatment failure, either relapse or stopping the drug for whatever reason. And these are the numbers, and they were pretty close to each other. It was a little bit less on the 14 milligram. That's a good sign, but in general, they say it's not statistically significant. That means that the change could have been by chance. Okay, there's a little bit difference. Now, there is some major or important things that you need to be aware of with Aubagio. It's one of the biggest things that you cannot be pregnant or planning to be pregnant on this drug. It's called pregnancy category X. That means that it may cause serious birth defects in the baby. Okay, so if there's any chance of that, please do one or the other, not both together. And of course, liver toxicity has been reported, including a fatal one. And that's why you watch the liver function tests periodically, that I'll talk about in the next slide. The slide afterwards. So the way the more common side effects are, but less dangerous, things like diarrhea, nausea, alopecia stands for hair loss. It can cause. It can be liver failure has been reported with a sister drug, the levoflunomide, and certainly there were some elevations also with the teriflunomide or Aubagio in the clinical trial, so it's recommended to watch it. Certainly got to watch for TB. Again, most of these MS medications reduce your immune system activity, okay? That's why your risk for infections go up automatically. For different kinds of infections, for example, Gilenya was, for whatever reason, more for the viral ones. This one, TB, is included. Make sure you don't have any latent TB. And it also can cause peripheral neuropathy. Now, we already talked about, so I'm not going to keep reiterating that, you cannot be pregnant or planning to be pregnant while on this drug, period. Okay, that's as easy as it gets. Of course, if accident happens, you immediately need to report, take an activated charcoal, and if you want to wash it out, you've got to do at least a couple of years because of the longer half-life of the drug. Also, the drug can be present in a man's semen. It's not just female, so you got to be careful about if the man has MS and is planning to have a baby, probably some caution there as well. We talked about, I was going to tell you what the monitoring you're going to do. You're going to do this liver function test, blood count, TB skin test, pregnancy test, and heart rate, blood pressure. And afterwards, you got to do liver function test monthly to make sure the liver doesn't develop any new problems. Tecfidera. It's a third one that came on the market more recently. It's probably, to me, this is my personal impression, it has the least well-characterized mechanism of action. Well, they know what it does. It activates this nuclear factor, E2-related factor, NRF2 pathway, okay, if it means something to it, for you. So it reduces oxidative stress-induced neuronal death and supposedly protects the blood-brain barrier. Now, a lot of these things I found in literature, I'm not saying that's not the case, but I would like to see a little bit more of a how, why, like type of definitions. So I don't think we understand mechanism of actions as well as I would like to. Let me leave it to that point. They did some clinical trials as well. So placebo-controlled study, they compared to Copaxone, again, 1,500 patients, pretty good number. And these were the numbers that came out. Placebo patients relapse approximately every 2.5 years. The BG12, that's the same thing as Tecfidera, about once every 5 years. Again, converting numbers for you. And glatiramer was, I guess, between every 3 and 4 years, 3.5 years. You could extrapolate that. So they initially studied twice a day and the 3 times a day dose, but it turned out to be that they were about the same, so they stuck with twice a day. There's no reason to. Some common side effects, flushing and GI upset. They did have some elevations of the liver enzymes in phase 1, 2, and 3 studies. That means that probably liver should be watched here as well. Okay, recent update. Very recently, actually, there was a death in Europe. Somebody had PML. It's a deadly virus infections that people a lot of times link with Tysabri. There was a case of that with Tecfidera, and that was very publicized. And again, I can remember. I think it's also close to 100,000 people, maybe more, maybe a little less, on Tecfidera that are on it now. One PML death, does it make the drug bad? No, but certainly raises a concern. So something for you to know. So they changed the label. Certainly people can be very allergic to it, develop swelling, and this lymphopenia basically means a low white cell count. Recommended monitoring every 6 months. Now the person that died apparently had a dropped cell count for many, many months, and they didn't pay attention or something. So what it sounds like, now I'm not going to blame anybody for it, but what it sounds like, it was not, no action was done at some point, and maybe that's, if they stopped it, it could have been better outcome, who knows. Now, so we're through the main oral section here, when to consider it. Patient preference definitely plays a role, but don't get me wrong, I only do the patient preference if we're starting as a new start. If patient is on something already, I use more of if it's working or not. If the needle injections are working great, just because patient, prefers pill, I try and I advise them not to make a decision to switch it. If it's just if it's a bad side effects, that's a different story. But just like everything else being equal, they say, oh, I just don't like needles. I'm like, well, can you take it because everything is stable? I would not like to rock the boat. It's very, very important that, of course, anybody is going to have preference to switch to pill. I don't doubt that. I don't know many people who would prefer injectables, but you got to put a little more thinking into it. Of course, if they're intolerant to whether it's an injection or any other first-line therapy, then there's a good reason to switch. And the first failure, same thing. There's some other special circumstances, such as patients who are on Tysabri for more than 2 years. The risk of getting this deadly disease called PML raises. So some people just say, oh, that's my cutoff. I don't want to be on it for more than 2 years. So that's kind of special circumstance. But usually, most common reasons I would say is this middle two, is that either it's not working or it's harming, okay? Rest of it we're pretty clear, we know what's preferred, of course, pill. Physician preference, yes, I think everything else being equal, a lot of physicians have their, again, everything else being equal, have their favorite drugs in the absence of a better term. But I would say it's more appropriately to word it is more the drug that they're most comfortable with. Okay, if they work the same, but I've used this one more often, I'm comfortable with it. I have a system in place to monitor this drug. Yes, you'll see those differences. But I think singling out everybody on too much on one medicine and not on the other, I think that's not a good practice either. Unless there is a reason for it, good reason for it within the medicine, etc. So yeah, these are the typical choices. So what happens if the first-line therapies are not working and brain is on a fire, okay, relapse after relapse? Well, we have some of the second-line agents, such as Tysabri, that's getting actually increasingly popular, especially now that we have a handle on understanding its main complications, the PML. Again, keep repeating, PML is a viral infection of the brain that can develop, or is higher chance of it developing somebody on Tysabri that can be lethal. So once we have a good control over it, people are prescribing more and more. What it is basically a bunch of molecules that look like this, given every month or every 4 weeks, I guess more precisely. Again, not apples to apples, but reduced attack by 68%. That's pretty higher, much higher than most of the other numbers that you have seen, like in mid-30s, remember we talked about platform therapy. So while there is not a clear study comparing this one to Avonex or or Betaseron or Copaxone, etc., I think everybody that I know, neurologists, would agree that Tysabri is stronger than most, if not all, medicines on the market. Now, Lemtrada just came out, so they may have a little tough competition there, but as far as most of the other medicines, again, it's not apples to apples, but it's generally considered as a more effective drug, yet at the cost of a more potentially deadly side effects. But you can, what you can do is choose smart and minimize that chances of anybody having some serious complications from it if you pick the right patient. This is what the PML stands for, progressive multifocal leukoencephalopathy, and these are some of the symptoms of it. I won't go in details of each of them. It's pretty self-explanatory, but cognitive behavioral weakness, a lot of this actually may feel like MS flare-up, believe it or not, except if the patient is on Tysabri and they call me with one of these that's new, I immediately start checking for this PML. I mean, that's not just give steroids as a knee-jerk reflex. That's different for most of the other medicines. This JCV is the actual virus that causes PML, just the name of the virus. There's a bunch of tests. Again, I won't go into details of it, but we have tests that can check the patient if they have the virus in the blood or not. And those patients who do not have the virus in the blood, they're at much higher chance of a good result or not getting the disease. Obviously, if you don't have virus in the body, you can't develop disease from it. So it has improved our ability to pick the right patient, so to speak. And some of the risk factors that, what are the chances of me getting this bad condition? Well, this basically serostatus means do you have the virus in the body or you don't, plus or minus. That's what it is. Prior immunosuppression, being on the drugs that were suppressing your immune system in the past, it seems to correlate with whether you would get the disease or not. And of course, being on Tysabri more than 2 years seems to increase the chances of developing PML. Really, well, we'll probably have data beyond 4 years, but it's more like, still in the relatively early phases, I would say. And here's some numbers. We talk about, speaking of a car crash, in 1 in 100, right? So in the worst average, I would say it's 1 in 1,000, in just average patient. But in the worst case patient, like who are positive with the virus, they've been immunosuppressed, etc., it's about the same risk in getting in a car crash, okay, or dying out of car crash. So that's, but I mean, this is serious. I mean, this is probably one of the most feared complications of any kind of MS treatments. I'm not trying to underestimate it. Well, the way we prevent this is we do MRI, then we either repeat the MRI periodically, or more importantly, evaluate the patient every 6 months at least. And of course, if suspected, we got to trigger the whole cascade of events of stopping the drug, checking for the virus if it's active in the brain with a spinal tap, etc. Okay, and we're on the last 2 slides. I edited these slides just, for this talk, because most of my other talks I haven't really needed it because the drug was not approved. It's the newest addition to the MS disease-modifying treatments. It's called Lemtrada. Its other name is alemtuzumab. It's same class molecule as you saw Tysabri. It's called antibody with the 2 spikes on each side. That's they're called monoclonal antibodies. Okay, and it selectively attacks certain proteins on your immune cells that are supposed to decrease the activity of immune cells that are involved in the formation of brain lesions, MS flare, etc. Now, it has a couple interesting points to it. The drug has. One is that it's a yearly dosing. You get it once a year. You basically, you get it at the beginning for 5 days, and in a year you repeat it for 3 days. That's it. And then they did pretty good. They compared it to Rebif, and they had some really good results. The relapse-free patients on 2 years was almost 4 out of 5 patients did not have relapse after 2 years of being on this medicine versus Rebif, I guess every other patient, a little bit less, had a relapse, 59%. And then they flipped the numbers a little bit. It's called annualized relapse rate, how often you have relapse if you're on this drug. And this was less than once in 5 years. Again, tweaking numbers a little bit. Oh, this was maybe every, just estimating, 2.5 years or so. Okay, so twice more there as well. And this is just some of the concerns. Lemtrada does have quite a few side effects. Most notable, two, are quite severe thyroid disease. It could be usually hyperthyroid, or it could be hypothyroid, or high or low thyroid functions. Up to 23%. This is a high number. Or 1 out of 4 people will have will develop thyroid problems on Lemtrada. Luckily, most of these are treatable, but who wants to mess up their thyroid if they don't have to? Another one is immune thrombocytopenic purpura. Basically, what it means is that your thrombocytes get destroyed, and you may develop bleeding, clotting, all kinds of complications. So it's about 3% cases. And that's about it. I think we're right on time, right, Stuart?
We're right on time, yes.
Good. So I'll use it for a Q&A session. And again, yes.
So for the Q&A, I'm going to go around the room with this microphone, okay? And we'd like you to ask your questions into this microphone. If you find that you want to get me to exercise a lot, run me back and forth around the room. I could use a little pounds to come off, all right? Please wait for me to come to you with the microphone, so that way everybody here can hear you ask the question. And again, these cameras are not on any of you, but we want to hear it so that way everybody out there can actually hear your question as well. So, I see a question starting there. Where will I be going after that, though? Okay, I'll go right next door. All right, I'll be there in a minute.
Thank you, by the way, for bearing with me with this intensive information flow. I usually like to do less material in the 15 minutes, but I just want to say that out loud. But hey.
Well, again, we loved him doing this today because we like to provide a comprehensive program. And that's an A to Z of all the treatments and the symptoms available out there. Thank you again.
No problem. Yeah, thank you.
So let's go to the last drug you were talking about, the
Yes.
Lemtrada. That's I noticed that's one dosage a year, maybe even the second year, maybe 2 doses or so.
Yes, 2 doses.
So you compared it to Rebif, and those of us who knew Rebif know that it's $59,000 a year for taking Rebif. So what if you take 1 dosage a year? Is that also $59,000 for the 1 deal?
Actually, just for my interest, I went and researched the price. And the literal wording that the company had was until, well, I actually don't remember the literal wording, but what it really meant, until they finalized the deal with the insurance companies, government insurance, etc., their own marketing things, they did not want to release the price. I would imagine, completely my thought, the way they market the drugs, that it'll be somewhere in the same ballpark or if not higher. The trend has been so far of the 10 medicines has been like this. The trend has been, price has been increasing. Most of them, there are exceptions, there are notable exceptions. So I would imagine it'll be close, maybe higher. I don't know. But I specifically looked it up today, as a matter of fact. I was wondering if there was any news, and Lemtrada and pricing was not.
I don't understand when you're talking about like a 2-year trial and it says 78% or whatever didn't have a relapse.
Yes.
Well, if you're on no medication, you could go 2 years with no relapse. So.
Excellent point. Yes. I'm sorry, to finish the question, I was so excited that I was... Is there any second part of the question? So just kind of explain the paradox?
I don't understand how they can come to any kind of conclusion about what the percentage is if it's just 2 years.
Exactly. So that's why they did... What you just said is a great example of an individual person. I have people who have not had a relapse for 10 years. They're walking, they're fine. That's why what they did, they picked 1,000 patients. So it averages out of everybody. So the numbers are averaged out on all these patients that you had. The 78% of... Let's say if they had 100 people, okay, 78 of them did not have a relapse by the end of the 2 years, versus those who were on Rebif, I think it was 59, if I'm not mistaken, of the 100 did not have relapse. So average. Does it answer your question, or?
Well, I just want to say,
judging it for 2 years.
Yes. So the reason to do that, even if you go 2 years, I have plenty of patients. Our experience with MS for many years showed that just because you're not having relapse for 2 years or 4 years or 5 or 10 years does not mean you won't have it all of a sudden worsening. I've had several cases, not just one case, just to scare everybody, that where a patient was stable. They said, "Oh, I don't need a drug." They would come off of the drug and they would just go down the hill very fast. So that's the rationale behind it. Basically, being on the MS medicine has proven to be ultimately necessary thing. Whether it's Rebif or Lemtrada, doesn't matter. Yes.
Hi, I have 2 quick questions. I actually have a ton, but I won't hog the mic. The first one is on the Tysabri. You said that when performing a JC test, I saw it said shouldn't be performed within 2 years of a plex, or 2 weeks of a plex. What was that?
Oh, yes, thank you. I was, again, part of it being focusing on the most important. So plex means plasma exchange. It's one of the procedures that you get. It's similar to dialysis. What it is, it's cleansing your blood out of the bad proteins. Okay? So checking for JC virus is actually checking for some of the antibodies that you develop for the JC virus if you have them in the blood. So if you had recently cleansed your blood of all the chemicals, that could go with it. So it will be recently cleaned blood, won't have signs of JC virus in there.
Okay.
Does that answer the question?
That,
So
very clear.
stands for plasma exchange. Thank you for
Yeah, thank you again, because you've been very clear. I've actually recently been diagnosed about 2 months ago, and I have no treatment yet. I'm in relapse, but don't have any treatment, so this is perfect for me. They want me to take Tysabri, so I have tons of questions, and I won't, again, inundate everybody. But just because of the progression, I heard you did say that usually you don't go to that first.
Well, it has been changing, yes. I want to say that majority of the neurologists do not jump to it as a first choice, correct. Right. But I have placed patients as a first choice on Tysabri. Not often, but I have, and many other well-known, even longer experience than myself, neurologists have done plenty of times. Okay. It's very selected cases, though, rarely.
Okay, so what would, I guess, cause you to choose someone to go that route instead of?
We're kind of, this is probably as deep as I would go in what sounds like an individual advice, but a general rule of thumb is that, first of all, severity of the disease. If the disease is not severe, I wouldn't really consider Tysabri. And the second, if they are at their status of their JCV in the blood, it would influence my decision some. If they have a virus in the body, less chance. If they're virus-free, sure, it's minimal risk, really. So those would be 2 factors. But severity of the disease is a primary driver. With a bad disease, it's definitely something to think about. With a mild disease, not really.
What causes electric shock type feeling? And does that mean that the current therapy that you're on is not working? And how do you treat it?
Oh, great question. Actually, I love that. Is it like a feeling in the back in the spine, going down your spine, or where?
The feet.
Legs? Yeah.
The legs and the
arms?
Arm.
Yeah, it could be. You got to be careful. If it's so, more than MS can cause electric-like shock feeling. For example, peripheral neuropathy can cause some tingling numbness. Usually not described as electric shocks. They usually call it more numbness. But again, I want to point out that it's not necessarily due to MS. However, it's commonly due to MS. So having said that, so if it's a new thing that develops, you never had it before, and it develops, it could actually be a flare-up. It could be worsening of the disease. What causes it is that there are certain fibers in the spinal cord, most notably, that convey the signal, the sensation to the arms and legs. And if they develop a lesion with them, it kind of tickles them, irritates them all the time, so you have this tingly feeling. It's almost like rubbing, the funny bone that you have here. If you rubbed it all over the edge of something, it kind of had this feeling. You're tickling the nerve here. Well, that's what the lesion does to in the absence of a better term, in the spinal cord. That's what causes it. Now, if it actually went away, it could mean one of the 2 things. Maybe the attack is better, or the other thing could mean is that maybe the nerve got burnt to the point that you can't feel anything anymore. I mean, that in rare cases. So, does it answer the question?
Well, it started about a year ago.
Right.
And when it initially started, it started in my foot. Whenever I went to walk, the shock would go from my foot up to the center of my thigh. And since it's been going on and I hadn't gotten any treatment for it, it's now in my left arm. And it doesn't feel like you described. It feels like I've actually put my finger in an electrical outlet, and the shock, it's just, I used to wear this walk aid that shot electricity into my thigh. I had to stop wearing it because I'm already being shocked. So I couldn't tolerate the walk aid anymore.
Well, you're pushing the buttons of my doctor self, like being already advising you, like, oh, I know what it is, but I don't want to. I can't say that. So just to give you a general advice, it actually could be more than MS flare. It could be something like, especially in the legs, like going like this. Could be a pop disc in the back or a pinched nerve. Possibility. So this is something that you definitely need to have a face-to-face conversation with your MD. But I wouldn't lock down to, based on what you're telling me, I wouldn't lock down to this being caused by just MS.
Okay. Thank you.
Sure.
Next question. Everybody, I'll get around the room. You just got to hold up your hand, and I'll be able to get to you. So seeing it up, I can get to you a little bit easier than waving the wand around.
I have two questions. The first one is, if you already have thyroid disease, then how would Lemtrada affect that? Would it make it any worse?
That's we call a kick under the waist, or what's the
Catch-22.
Catch-22, yeah. Yeah, there's a saying in Russian. I'm originally from, well, not Russia, Georgia. They equate the two countries. So we have a similar saying, and it's translated differently. Like, we're kicking the loin or something, I think. Anyway, so that's a very tough question. I think it would certainly decrease anybody's chances of getting on it if you already have a problem. It could, most logically, would only make it worse. However, I wouldn't eliminate it. I think if MS is just causing you to go downhill like very fast, and all it's going to take for your thyroid to increase your thyroid or decrease your thyroid medicine a little bit to counterbalance it, again, theoretically speaking, I wouldn't eliminate the chances of being on Lemtrada. I think it's possible.
Okay.
Yes.
Thank you. I've also heard that a lot of people with MS get Raynaud's. I think I'm pronouncing it correctly.
Correct. Yes, they do.
And lately, when I go out in the cold, I'm in pain in my fingers.
So the question is?
Is that Raynaud's?
Yes, it is. Well, it sounds like. Okay, I don't mean.
That's what the question was.
Okay, well, Raynaud's is the blood vessel spasm in your extremities, and they call discoloration and pain because of decreased blood flow. Okay, the palms and hands become kind of like blotchy, and that's what she's describing now. Obviously, I haven't even been 5 feet close to her to examine her, but that's what it sounds like. There are some treatments, yes, definitely. There's some medications that supposedly work. So, but I think prevention of wearing gloves or something simple that I would pursue. Yes, ma'am.
My question is regarding the disease-modifying therapies and a person with MS or the DMTs. Yes. I've heard from numerous neurologists, because I've been to more than one of these presentations and saw it on the screen.
Yeah.
There's numerous ones say if you have MS, you got to be on some type of disease-modifying therapy, even if you, because you want to be on it because you want to, if you're relapsing remitting, you want to make sure that you do not progress on to the next one, secondary, whatever.
Yes.
So when I hear people say I'm not on anything, I'm like, oh, because that's all I've been hearing is you got to be on something to make sure you're slowing down the disease progression so that you don't go on to something worse. So but I'm hearing other people say I haven't been on anything for years, and I haven't been on anything for years, and I'm like, oh, okay. So is that a new school of thought, or is that only with some neurologists? What is the? I
have a very good answer for that. It actually goes back to partially to the gentleman's comment of if I didn't have relapse for 2 years. So let me give you the situation. I'm sorry, but I have to spend a little more time on this question because this is very, very important. Let me give you a theoretical future that maybe, I hope it doesn't happen, but let's say in 2 years or 5 years, you start developing weakness in the legs, difficulty walking, symptoms that we talked about. And let's say that had you been on the medicine, there was much less chance of that being developed. Would you still not be on the medicine? Or? Okay.
So your scenario was that
Exactly. Exactly.
Repeat what she just said, please.
Yes. Please repeat.
So in your scenario, you're saying that if I had been on a medication, I more than likely would not have come to the point where I had a problem with walking.
Yes, or many other MS symptoms.
Or many MS symptoms.
So to tell you the answer, I don't know any qualified, legitimate neurologist, not just MS specialist, neurologist with a license and a pulse, who, if there is a if there is a well set in stone diagnosis of MS, no matter how mild it is, that they would recommend not being on the medicine. I don't know anybody myself, not just the ones that are aggressive or actively very involved, anybody. So I don't know if you see any neurologist who told you not to be on it.
But I'm hearing people who, say they have multiple people who say, I don't take anything, and I haven't done anything. I'm like, oh. Because I've been hearing this, you need to be on something to make sure that you don't progress to the next stage. And so I'm like, for them, I'm thinking, I'm not like their mother or anything, but I'm like, oh, I don't, want to see them go on to a worsening stage. That's what I'm thinking when I hear them say that.
Yeah, I agree. I think I would totally be on the, you just don't know when if it's gonna get worse or not until it does, and then it would be, yes.
I never had a problem with thyroid issues until I started on Avonex, and now I'm on a max dosage of thyroid medication. If I were to change my medication, would my thyroid go back to normal?
That's a question that I don't know anybody in the world who could answer that question correctly with certainty. I would say two things. It's not necessarily caused by the other. I mean, thyroid disease is far more common than, I'm not even aware of Avonex causing it that much. It's not one of the common side effects. So my most likely expectations would be no, it won't get back to normal, but I don't think anybody knows for sure.
I wanted to ask a question. You seem not too impressed with Texadera. What is the problem? Because I'm on Texadera, so I'm I was trying my best not to come across as incorrectly come across as being impressed with one more drug than the other. The only thing that I was trying to communicate about Tecfidera is that I still don't know exactly how it works. It works. I mean, we have plenty of very legit clinical trials that works. Just the mechanism of action is less obvious. Like for example, if I drop the glass and it breaks, I see why, because I dropped it, right? So in Tecfidera, it's kind of more vague. But I would, if that's how it came across, I would cross that. That's not the case. I have plenty of patients who I have on Tecfidera, and I think it's, certainly a good drug. I mean, glad you spoke it rather than retaining it and taking it out. Yes.
Hi. What in general should the washout period be between drugs?
It very much depends. It could be anywhere from 0 days to 2 years. It very much depends.
Okay. Specifically, I've been on Tysabri for 6 years, and I've been off of it for 2 months, and I read that after 3 months, I just
2 or 3 months is a magic number that most people say. Yeah, for Tysabri.
Any other questions? There we go.
Several. Are we short of time?
We have a little bit.
Okay. You should be happy, Stuart. So many questions. Active audience.
I'm happy I'm getting a rundown.
Let me just mention, I had all my MS symptoms back in 1978, and I had them for about a year, and they're about the same symptoms that I have right now. And after a year, all my symptoms went away, and I call it going into remission. And I didn't have any MS symptoms for 22 years until I was in a bad skiing accident, and they all fired back up again. That was in 2000, and they've been quite active since then. So this goes back to the question of do you have to be taking a DMT all the time? I know folks in the Columbia area who don't take a DMT because of price and because of side effects, and they're not exhibiting a lot of MS problems. So it seems that Since in the 90s, since we started having some disease-modifying therapies, the neurology field has this one or these several medications that they know work, so they do recommend them. So if they don't take them, it's kind of up in air whether they really have any new symptoms or not. Like me, for 22 years I had no new symptoms.
I'm sure, should I answer or comment that this statement? The very, very legit and very good way to put things, like a real life example. One thing I would add is, again, going back to analogies, goes back to, let's say, changing oil every 5,000 miles in your car. I love cars, speaking of. So what happens if you don't change it until the 7,500? Does it mean your engine is going to start making noise? Or probably will be fine, right, if your engine is running fine? Or maybe changing at 10,000 miles. What happens if your car dies out on the highway at 8,000 miles because you didn't change oil at 5,000 miles, then you're going to be like, oh, I wish I did it. Nothing may happen. You may be like Bob was, until he could have not taken medicine until late 90s and then restart whatever. The problem is that you don't know until it happens, and you don't know which one it's going to happen to, which one it's not. So that's why it's better to, it's like aspirin, If you have a heart attack and you were not taking aspirin, gosh, if I took it, hopefully I wouldn't have as bad. That's basically what the same logic. All right.
Okay, so you mentioned something about, or we know that a lot of these during steroids treatments or anything else, they suppress your immune system. Yes. So there's natural things that people say you can use to increase or better your immune system. Is that counteractive to taking the DMTs and the drugs? Do they really help? Is it a feel-good kind of thing?
I can give you my perception of it. One thing I've noticed is that majority of the things that are advertised on the internet, the immune boosters, they have no or close to no evidence that they actually work, like no proof. Somebody thought it works, or somebody had some, I don't know, dream. I mean, I don't want to offend individual supplements, but basically most of them are not in the way of DMT. I would certainly ask you to cross-check with your doctors, because some of them are really weird. Okay, try to shrink down my answer. They probably neither help nor harm, most of them. But again, I have to see an individual one to give you a better answer. That's my perception.
Okay, and then this one's not directed to you per se, but you guys talked about some support groups. Is it just for MS people, or is it for families and friends as well? Or are there separate groups for those individuals?
The care groups are support groups are for everybody. In my support group, half of the members in my group are family members. And often MS people do not want to come to the meetings, but their caregivers do. And so they come and get a lot of information. They take it back to their persons.
Any other questions?
Yes, over here.
Where? There you go.
I can see so much more from his story. Sorry.
Can you address? I think it piggybacks on what she said. Can you address vitamin D and the impact that vitamin D has on a person having less relapses if they take vitamin D, and the number your vitamin D level should be at to make sure, because MS people have a different number than regular people.
Very, very, very good point. So the vitamin D is a growing, very popular, and I think very important topic in MS community. While it's not to that science level that if you take vitamin D you're going to have less relapses, we don't have that information yet. It's been a lot of different reports from different angles that it helps people feel better. There's less fatigue, certainly, those kind of things. And in the labs, it's been replicated that immune cells are less autoimmune if they have proper vitamin D. So, long story short, I think every patient should be checked with vitamin D levels, whether they have it low or not. The number is 30 to 80 or 90, I think. Different labs measure differently. That range, and you should, if you're low, taking a supplement unless you have a reason not to. Like there's some contraindications of you can't take too high doses. I think it's reasonable to take a supplement. Typical doses I've seen is between 1,000 and 5,000 a day of vitamin D, and it's measured in international units or IUs, not milligrams. Those are them.
Bob here was talking about the price of Lemtrada versus the others. My understanding is that with Lemtrada, you do like 5 infusions the first year, then 3 the second, and then you're just done, right? You don't ever do it again.
Yes, yes.
So it's ultimately much cheaper, right?
Yes. Well, we don't know because we don't have a long-term data. That's the thing, and we don't even know the price of it. That's a good point. So depending on how much the price is. And one thing that's kind of downside of Lemtrada is that, well, what's going to happen in 5 years? Maybe you're going to need to repeat dose because the study has not been long enough for 5 years. So it's yes and no. Like, if I.
Okay. Again, any more questions? I don't see any arms up.
Back.
Wasn't I just there?
Help you. You talked about Lemtrada and ITP.
Yes.
But you said nothing about deaths or anything related to it. Is it because the 5 years nobody has been on it for? I mean, you have no data?
No, we don't have 5-year data.
It's just small.
Yeah,
Okay.
You know, actually, I have to look in if anybody has died. I can't think off the top of my head if anybody died from it. I don't think so, but I have to go back to trial and see it. And obviously, I have never used it before, so I'm not as familiar with the drug as every other one. But I wouldn't answer you yes or no on that one yet. If anybody knows, by the way, if somebody died from Lemtrada, I'll be glad to, you know.
This question is just kind of to piggyback as well in regards to Lemtrada. Don't you have to be, is like everyone in general isn't qualified to be on that drug? Like, what are the specifics to be qualified for Lemtrada?
It's mostly it would be, I think, from my understanding, is that it's not indicated by the first episode of MS. Well, I know that for the fact. It's not indicated for the CIS or clinically isolated syndrome. That is basically your first initial MS diagnosis. So it's indicated afterwards. So for established case of MS, that's one indication. The second is that obviously, as a lady here up front said, if you have a thyroid problem existing or some sort of a thrombocyte problems already existing would not be the right choice for you. I think if you have an HIV is another reason because it suppresses your immune system more would be another reason to be. There's a few points there that you should go over and be careful before you start it.
I have a question for you.
Yes.
What's your perspective on the future for disease-modifying medications for SPMS and PPMS?
Yes. Yeah, that's SPMS and PPMS. Those are the progressive forms of MS that Stuart mentioned. Very, 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 speaking of invisible impact, like a lot of people here I see may have secondary MS. Don't get me wrong, I could spot it out. I think it's the treatment, very effective treatment is very close. I've been very much involved in this Future of Medicine conferences recently, and there's some really amazing stuff in one like individualized medicine to calculate if this medicine work on you or not. So while we don't, one of the trials, by the way, they did a study, which drug was it? Just said that it wouldn't work. Was it Gilenia or no? It was a trial that, I'm blanking on it, but there was another drug that they tried in SPMS that didn't work. But I think in the next 5 years, I'm very, very optimistic and realistically hopeful that we will have a drug for SPMS.
Wait, we have another question. We have 2 questions.
Yes.
They like seeing me go all the way to the front before they ask.
Which do you think will come first, secondary progressive treatment or the cure?
Secondary progressive, I think. I think we're closer to that.
Yes. Are you familiar with where they are with the Lingo trial stage now? The Lingo, the drug that's all of these talk about are slowing. When you talked about all disease modifying, slowing it down, but Lingo is like one of the ones that is going to repair the damage that MS has done, and they're supposed to be in some kind of trial phase. And I just wanted to know if you had an update as to what trial
I know
phase
what you're talking about. I don't know the details of the trial, but it's in the early enough stages that it's not. It's not to the point where we could make a conclusion. Oh, it's definitely going to work or not. But I know what you're talking about.
Okay, now that I'm all the way up front, is anybody in the back again? There we go. See? I was just kidding. There you go. Well, we do have another one. This is the middle of the back.
I have a problem with swallowing. Sometimes it's hard. It's not all the time, but it just seems like it just won't go down. that's MS, isn't it?
I wouldn't. It's possible that it's MS. It's not as common for MS to develop swallowing problems, but I certainly have patients who have that. So, but there's so many other things that can cause swallowing problems that I would certainly get evaluated for it. But please do not assume it's MS. That's my one advice.
Because there's sometimes there's a feeling that something is there. I have that too. And I guess I blame MS for everything, but I guess I really shouldn't.
I can tell you one advice for sure, and individual literally, that do not blame it automatically on MS. Do get checked out professionally, and it may be something else.
So not necessarily, not a neurological thing. It can just be talked to my
exactly.
primary.
GP, usually general practitioner, and they may refer you to the GI, the gastrointestinal doctor. But I would not settle on it being MS.
Thank you.
Okay, now to the front of the room. We're going to zigzag, okay? We have another 5 minutes left of this, and then we go on to our next speaker.
Recently, I had a fracture in my foot. I have no idea, does MS affect your bones or?
Excellent point. Not directly. It does not. MS only affects the central nervous system, that's the brain and the spinal cord directly. However, MS patients tend to move less for a known reason, right? There's weakness, so you don't walk as much, you don't exercise as much. That would weaken your bones. Everybody. So within the bones, it's more prone to fracture. So steroids would make it more prone to fracture. So indirectly, yes.
Well, this is really the question. This addresses what she said with the throat thing. It could be, like he said, go get it checked out because it could be an allergy. If you notice it when you're eating something and it kind of swells up and you can hardly swallow it, that may be allergy related. Yeah, well, it could be one more.
Okay, any other questions? I have one. Right. Well, I first have a statement. First, I want to thank Dr. Mrelashvili.
There we go. Thank you.
And lastly, did Joel learn something today? Yes. Thank you. So now we're going to thank Doctor again, and then we're going to go on to our second speaker.